dialogue in the Maternal Nutrition Technical E-Dialogue series. I, Rajni Peter, the coordinator of today's program, I'd like to thank you on behalf of ICMR National Institute of Nutrition, FOXI, and UNICEF for taking the time out of your day and joining us. Our partner agencies are Alive and Thrive, Nutrition International, Society for Applied Studies, Institute of Economic Growth, and Sight and Life. Whether you're joining us from our January webinar or are here for the first time, we hope that through this series, you will join us in exploring the ways by which maternal nutrition assessment and services in antenatal care can be strengthened in India. In today's webinar, we are discussing the role of women's group and the ways in which they contribute to improved maternal health and nutrition. In our midst, there are acclaimed academics and experts in the field who are here to share their countless years of research and experience. If you have any questions, please feel free to put them down in the Q&A box, which, as per the availability of time, will be answered by our experts. And now, let me introduce Dr. Bharti Kulkarni, Scientist F and Head of the Department of Clinical Division at ICMR NIN, a Senior Scientist and Deputy Director here at NIN. Madam holds an MPH from Johns Hopkins Bloomberg School of Public Health, USA, and her PhD, and she has a PhD from Queensland University of Technology, Australia. Her major research interests are in the areas of maternal and child nutrition, anemia, body composition, and developmental origins of health and disease. She is currently leading studies in the areas of anemia and childhood stunting. Over to you, Dr. Bharti.
Thank you very much, Rajni. I'm very happy to welcome you all to our third webinar in the series of monthly technical e-dialogues on maternal nutrition convened by ICMR NIN and FOXI. In our previous two webinars, we had very informative discussions on maternal thinness and maternal obesity, two very important issues of public health importance. We have been following a consistent pattern for our webinars. In the first hour, we have a detailed discussion and presentation by eminent speakers on the available evidence on the extent of the problem, determinants of the problem, and what is the available evidence on the impact of interventions. This detailed presentation is followed by a panel discussion, and our panelists usually discuss their views on potential solutions and what works in different contexts. Our panelists usually are a mix of researchers, clinicians, public health experts, and program implementers. And I'm sure that our participants for the past webinars benefited immensely from the knowledge and experiences shared by the speakers and the panelists. Today's webinar is structured in a similar manner and deals with a very interesting and important platform which can deliver the health and nutrition interventions to vulnerable groups and has immense potential to influence maternal nutrition. I'm sure you're all aware that there is an increasing recognition globally that only food or nutrition specific interventions can have only modest impact on improving the nutritional status of the vulnerable groups, whereas nutrition sensitive interventions such as agriculture, women's empowerment, WASH interventions are necessary to make the requisite impact. Women's empowerment especially has been critical issue in the South Asian context. Way back in 1990s, Professor Ramalinga Swamy in his landmark paper on Asian Enigma highlighted low status of women in South Asia when he was comparing the worst nutritional outcomes of the children in South Asia as compared to sub-Saharan African context, where economic progress has been much better in South Asia. So women's self-help groups started way back in 1970s. In India have grown exponentially. These self-help groups, as well as other women's groups, offer an important opportunity for women's empowerment, and there is a growing interest in exploring these platforms as a delivery platforms for health and nutrition interventions. The evidence in this area has been mixed. Some studies have shown some benefits on few outcomes such as dietary diversity, whereas some studies have shown no benefits. So we will be delving deep into this area today, and we will learn from the eminent speakers and panelists who have very kindly agreed to share their experiences and spend time with us despite their busy schedule. We are very honored to have with us Srimati Neeta Kejriwal, Joint Director, Ministry of Rural Development, and for chairing this session. I'm very thankful to her for kindly agreeing to chair this webinar despite her busy schedule. She is Joint Secretary in the Ministry of Rural Development from the Central Secretariat Service. She has been associated with the design and implementation of Deen Dayal Antyodaya Yojana National Rural Livelihoods Mission from its inception, and she has extensive experience of working with different ministries in the Government of India. She holds training in public policy from University of California. Once again, ma'am, welcome, and thank you so much for agreeing to chair this webinar. I would like to request you to give your opening remarks. Over to you, ma'am.
Thank you, Dr. Kulkarni, and I'm really grateful to NIN and Foxy and UNICEF to invite me for chairing this very important webinar. I really don't need to tell this group here the importance of nutrition for women of reproductive age, especially during preconception, pregnancy, and postpartum periods. We all know that poor nutritional conditions before, during, and during pregnancy can have both short-term and lasting impact on the adverse impacts actually on the offspring. So. But the issue that we are going to discuss today, as you mentioned, is whether this issue of maternal nutrition can be addressed through the women's institutions. And we in NRLM, the National Rural Livelihood Mission, we believe that the women's institutions can be very, very useful platform for doing this work. And this is something that we have been doing as a part of our social development related initiatives. And many states have actually initiated a lot of work in this area. This has been a recent kind of development for some work in a few states. Some of this work has been started in the last few years, and many states are just starting. Some assessment has also happened, and as you said, a mixed kind of picture, but I think these are also areas of work which require to be done for some time before you can actually see a lot of impact happening in these areas. So I'll just start by giving a very small background of NRLM for the benefit of all those who are present here and do not know NRLM. So NRLM basically works for organizing rural poor women into self-help groups and their institutions. Their federations, like at the village level, at the cluster level federation. So a whole institutional structure is being created. And then of course we work for their financial inclusion, livelihood support, etc. Social development related issues, of course, is a very important area of work also. So as of now, we have started work in all the states and union territories in the country. And more than 7 crore women are actually part of more than 66 lakh self-help groups under NRLM. So this is the kind of expanse we have. This is the kind of, and we have about around 4 lakh village level organizations and maybe about 30,000 or so cluster level federations. So the whole institutional network is present in large parts of the country. And as I mentioned, we are also working on social development related issues. This includes food and nutrition related issues, and maternal nutrition obviously forms a very important part of these interventions. The strategy is both to create awareness on these issues, including diet diversity, etc., as well as how do you access the relevant services from concerned government departments like the health department or the women and child department, etc., from their programs. And we also work on trying to have access to nutritious food through certain suitable interventions, like, for example, nutri gardens, poultry, dairy, etc. And our experience has been that working through these groups, through this whole institutional platform that we have, really makes the work much more effective. And we are also able to actually use the social capital that is created under NRLM in the states, the community resource persons, etc., to take these interventions forward, to take this awareness generation, all these activities forward. So a lot of work being done in states like Bihar, which has been working with PCI. Again, Orissa, Chhattisgarh, Bihar have been implementing the Swabhiman project with the support from UNICEF. Other states like Jharkhand, Madhya Pradesh, Rajasthan, Maharashtra, etc. They are also working with different kinds of partners who are providing some technical support. So we found these institutions very useful for trying to seed this whole concept of maternal nutrition. And a lot of strategies are being taken up, like we have the village organizations having social action committees, and sometimes they actually do home visits, and which has been found to be a very, very useful intervention, particularly for counseling the pregnant and lactating mother, etc. Then there have been some interventions where peer counseling is done, where the pregnant and or lactating mothers would be called at a certain place for peer counseling instead of individual home visits, etc. So different kinds of strategies being used and found to be pretty effective also. We have, of course, been working a lot with the Poshan Abhiyan of women and child development, and all the Poshan Pakwaras and Poshan Mas. They actually provide us with an opportunity for giving it a further push and really creating that awareness about the importance of nutrition and maternal nutrition in the country. And of course, in a big way, we are working on nutrition gardens, some nutri-based enterprises, etc. also. So we also doing some, as I said, assessments, and out of the findings, we are trying to do some mid-course corrections, etc. So basically, I just wanted to give an introduction of the kind of work being done under NRLM, but I'm really looking forward to the discussion today to see what are the other examples available across the country, what are the other kind of interventions being taken up by different people, and how we can use these to even more effectively administer our own intervention. So I'll stop here and maybe come in later as and when required. So over to you, Dr. Kulkarni.
Thank you so much, ma'am, for your kind words and your interest in the program. We are all looking forward to the discussions. I'll hand over to Rajini to take this forward. Thank you.
Hello. Yes. So now, without further ado, let's proceed with the first session of the day, a presentation on systematic review of engaging women groups for multi-sector interventions aimed to improve health and nutrition. It is with great pride that I introduce Dr. Sapna Desai and Dr. Audrey Prost. Dr. Desai is an associate at Population Council, Delhi. She holds a PhD in epidemiology and population health from Lennon School and Tropical Medicine. She also has an MS in population and international health from the London School of Hygiene and Tropical Medicine. Her research interests are women's health and well-being in India, with a focus on community-based interventions, health systems, and sexual and reproductive health. She currently works on Global Evidence Consortium to strengthen the evidence base on women's groups for improved health outcomes. She has been affiliated with the global journal Sexual and Reproductive Health Matters for 10 years as both an advisory board member and an associate editor. Dr. Audrey is the director of the Center for Health of Women, Children and Adolescents, housed at the University College London at its Institute of Global Health. She has a master's in ethnology from Paris University and a PhD in social anthropology from UCL, and has also completed training in epidemiology at the London School of Hygiene and Tropical Medicine. She works in close collaboration with the Indian Civil Society organization, EGJUT. With EGJUT, she has conducted 2 large cluster randomized controlled trials of participatory women's groups to improve maternal and newborn health in largely tribal areas of Jharkhand and Orissa, eastern India. EGJUT trial, which was published in the Lancet in 2010, won the Society for Clinical Trials Award Trial of the Year in 2011. Thank you, Dr. Desai and Dr. Cross, for enlightening. I welcome both of you. I'm handing over the session for presentation. Thank you.
Thank you very much. And Audrey, Audrey's going to share screen 1 second. It is an absolute honor to be here with all of you today. So thank you again to NIN, to Foxy, and to UNICEF for having us here. And we are really looking forward to the panel and to hear your feedback, and also to share with you what we've learned thus far. So today, Audrey and I will be presenting findings from a systematic review that we completed last year, which was a mixed methods review to look at the evidence base on women's groups in India. And the reason we did this is that, as we all know here, that women's groups have been operating at scale through 2 programs in the country, really. Of course, the NRLM that Neeta ma'am just told you about, and also through the National Health Mission, through ASHA's conducting participatory learning and action in groups across several states. So we see women's groups being implemented at scale in the country to improve health, but there had not been a systematic review of the evidence till date. So we, in a team of us at the Population Council, at UCL, and also IFPRI, and all the names are here on the slide, we conducted this review together as part of a larger project being supported by the Gates Foundation to examine what has worked with women's groups to improve health and nutrition, and importantly, how and why. So we can help use this evidence to inform programs more effectively at scale in particular. So with that, next slide, please. So the objectives of our review were twofold. One was to examine the impacts that women's group interventions have had on women's and children's health in India. So really looking at evaluations, for example, and the effects they've had on outcomes. And the second is to examine the enablers and barriers to implementing these programs, and particularly looking at the intervention design, the context in which they were implemented, and also the characteristics of outcomes. Next slide, thank you. So we've reviewed 99 studies across India. I'm not going into our selection criteria here, but to tell you that we examined both quantitative and qualitative evidence. We had 99 studies, 44 of which were experimental studies, both randomized controlled trials and quasi-experimental studies across the country, though as you can see here, they've really been concentrated in a few states, particularly the experimental studies. And also 55 either observational quantitative studies or qualitative studies, both specifically linked to the evaluations, as well as studies that were standalone on women's groups. And the reason we did this is that we really wanted to examine the evidence base comprehensively to inform programming. And that doesn't only come from, of course, evaluations. Next slide. So the studies we found, if we look at the experimental studies, so the evaluations were largely, of the 44, largely examined outcomes related to RMNCH, to reproductive maternal newborn child health, and also 7, as you can see, and we'll go into greater detail today, focused on nutrition. So those are the 2 bodies of work that we'll speak to you most about today. But just so you know, the evidence base is actually quite broad and has also examined sexual health and HIV, violence against women, and to a lesser extent, health expenditure, vector-borne disease, and mental health. Interestingly, of these studies, Audrey, can you just press the next? Sorry. So of these studies, we had, as you can see, about half of them examined impacts on the population. So looked at population level effects on health and nutrition, but 15 of them only examined the effects on women who are in the group, so on group members alone, and then 2 looked at members and non-members. Next. And of the studies we examined, the risk of bias, we examined the risk of bias using standard tools, the Cochrane Risk of Bias 2 and Robbins for non-randomized studies. And we found that of the randomized trials, 4 were at high risk of bias, and the remaining 13 were of moderate quality or high quality. The non-randomized trials, however, we did see about half were at either serious or critical risk of bias. And this was largely due to something specific to groups, which is, of course, selection bias and women who choose to enter groups and then not accounting for that, particularly when the groups dissolve over time, for example. So the studies that tended to measure population, public health, effects on health and nutrition tended not to have those problems. Next, please. So just to note, and as a great overview of the diversity of groups in the country, about 24 of the studies we examined, of the experimental studies, were self-help groups. There were SHGs, 17 of which were implemented by the government, so through one of the SRLMs that Neeta ma'am had just mentioned, whereas the rest were through NGOs such as Pradhan, and we have Madhu Ketan here today from Pradhan. So we had a big chunk of the SHGs, but we also had a large set of studies, about 12, what we call open groups, which were groups that are open to all women. These are similar to what Ekjut has implemented in Jharkhand and Orissa, what we've seen with Swabhiman in Chhattisgarh, or also Sneha in Bombay. So these are groups that are open to all women to attend. So they're like community groups, but they tend to focus on women, and they apply different principles typically. The other types are special population groups, most commonly sex workers collectives. There were 2 that focused on mothers groups, which is of special interest here, of course, to the audience. And lastly, broader community-based groups that were either open or closed, groups of women members that typically work towards broader development objectives. And a good example of this is SEVA. And I will add that my real, I think, credentials to look at this evidence base, of course, come from the academic background, but also I had spent a decade working with SEVA, implementing our health programs and scaling them up in several states of the country. And my old colleague Sanjay Bhai is on the panel, and I really look forward to kind of going down memory lane with him as well to remember how we did implement programs and what both the challenges and enablers were to that. So at that, I've given you an overview of what we studied. I'm going to turn to Audrey to talk to us about what we found.
Thank you so much, Sapna, and good afternoon, everyone. It's a real pleasure and honor to be in your company today. So as we examine the studies in our systematic review, we actually identified 3 ideal types of group interventions, and these were mapped out here by our colleague Lou Graham in a companion article to the systematic review. This is a very simple typology, and it looks at 2 main axes: the style of social and behavior change approach used with groups on the y-axis, and the scope of capacity building on the x-axis. In the first ideal type, which we called the classroom, the idea is mainly to build individual group members' capacity, and primarily by giving them information. In the second type, which we called the club, the idea is to start to leverage group dynamics and build group capacity, which can be done by giving the group members information, but also by engaging them in forms of problem solving. And finally, in the third ideal type of group intervention, which we called the collective, the group actually becomes a lever to build community capacity beyond the group membership. And here we tend to see a bigger emphasis on collective problem diagnosis and collective problem solving. We're not claiming that this typology is perfect or fits with all types of group interventions, but we're mainly using it to help us think about clusters of group interventions as we go along and discuss the results of the systematic review. I should have highlighted, sorry, that much to our surprise, we found that more studies in the systematic review actually used collective types interventions, 16 of them did, and fewer used club type interventions, and fewer still used classroom interventions. So that's an interesting distribution of types of group interventions in the literature. So what did we learn from the experimental studies in this review overall? I'm going to give you a very rapid tour of the results for nutrition sensitive but not nutrition specific studies, because they all belong to domains that of course have relevance for nutrition. In the area of reproductive, maternal, newborn and child health, we found that collective type interventions that did problem solving activities, engaged community members beyond the group and did community capacity building actually led to reductions in neonatal mortality. And that's work done by Vishwajit Kumar and colleagues in Shivgar in UP, as well as by colleagues at Ekjut in Jharkhand and Orissa. There were many different types of interventions with SHGs that led to improved self-reported behaviors during the perinatal period, including improvements in access to antenatal care services and essential newborn care practices, especially early and exclusive breastfeeding. And these were reported in many evaluations with SHGs. There were few interventions with groups from urban areas, but the one that did exist, unfortunately, showed no effects on any RMNCH outcomes. The 4 studies on violence against women included 2 very well conducted studies with SHGs linked to the Women Development Corporation in Bihar and the Safe Cities initiatives in Madhya Pradesh. And they found little evidence, unfortunately, of any effects of groups and gender awareness training with SHGs on reducing physical, sexual, and emotional violence. They did find some evidence that the programs made women less likely to find violence acceptable. We found several studies that suggested positive effects of community mobilization, so collective type approaches with SHGs to control vector-borne diseases, including dengue and malaria, with impressive results on both objective measures of vector density and also preventive behaviors from both Tamil Nadu and Orissa. I won't delve too much into the sexual health and HIV interventions, just to say that again, community mobilization here seems to have better effects than other types of approaches. So sex worker collectives, for example, taking part in community mobilization decreased STI prevalence in several studies. So now let's jump straight into the nutrition-focused results. We found only 7 experimental studies that had nutrition-specific primary outcomes and 10 studies with nutrition secondary outcomes. And most of these were studies conducted on the perinatal period and had breastfeeding outcomes. There were also 5 observational studies that related to groups and nutrition outcomes, and most of these described programs. And we also find 5 qualitative studies that examine the context and the mechanisms of interventions. Of the 7 experimental studies, 5 were conducted with SHGs and 2 with open women's groups, i.e. groups with open membership. So the interventions tested in experimental studies really looked at 3 different types of approaches to working with groups to improve nutrition. The first is starting and strengthening SHGs, but without adding a specific nutrition intervention. And here the expected pathway to change is really about increasing income and consumption, and through this dietary quality and healthcare seeking. And one program that explored this in great detail was IKP in Andhra Pradesh. From there on, a natural step is to do what has been commonly now called layering of nutrition education onto existing SHGs to increase their knowledge of nutrition-related practices, and with the hope that potential economic benefits of belonging to the groups, the social capital that it might generate, and the nutrition knowledge being offered would address both demand and supply-related issues. At the same time, there were other approaches being tested with groups that were open to all community members, notably in studies by Ekjut with participatory learning and action, and other complementary activities. These interventions really emphasized going beyond knowledge transfer to provide a space for communities to prioritize and solve problems which they identified. So this now leads us into a new generation, a new set of interventions, some of them still being evaluated. And in these new interventions, community mobilization approaches that really harness problem solving using microplanning, participatory learning in action, and other community capacity building activities are being done with SHGs. And the Swabiman program in Bihar, Orissa, and Chhattisgarh is an example of this new generation of programs. So I'm now going to share the results from studies that evaluated the first three types of approaches: SHGs without a specific nutrition intervention, SHGs with nutrition education layering, and finally community mobilization. We've talked about the IKP program in Andhra Pradesh. The studies by Deininger and colleagues assessed the effects of SHGs on consumption, women's energy intake, and asset accumulation. IKP formed the SHGs, but they also strengthened the federation structures. And they also established some direct nutrition interventions. For example, they encouraged village-level SHG federations to essentially take over the public distribution system by acquiring subsidized rice in bulk and making it available to SHG members as an in-kind credit. They also gave SHGs loans to purchase dairy-producing livestock, so some fairly direct nutrition interventions. They found that these activities led to significant increases in energy intake, and these are reported here for women, protein intake, and food consumption. They hypothesized that the protein and energy intake increases might be due to the offer of funds for livestock purchases, which were taken up by about a quarter of SHGs, and also to the rice credit lice system, which was taken up by around a third of SHGs. Encouragingly, they also found that longer exposure to the SHG program yielded greater results on these nutrition outcomes. What about interventions that try to layer nutrition education onto SHGs? Well, an excellent example of this comes from the Jivika Multisectoral Convergence Pilot Program in Saharsa district in Bihar. They wanted to improve nutrition outcomes for women in SHGs and their children through behavior change communication and by strengthening access to services and entitlements. In practice, they did this by disseminating messages on maternal and child health and nutrition to mature SHGs through bi-monthly meetings, and the meetings themselves lasted an hour, but there was only 10 minutes of discussion on health and nutrition, and they did this for 2.5 years. They complemented it with targeted home visits, peer group meetings, and community events, but the focus of these was still very much on educational and on sharing information. There were planned meetings between block and district level coordinators to try and increase the coordination between ICDS workers and Jivika community mobilizers, but unfortunately, these were discontinued during the program. The evaluation of this Jivika program had two primary outcomes: child dietary diversity among children aged 6 to 23 months and maternal BMI. And the program found good effects on child dietary diversity, as you can see here on the green box above, but unfortunately no impact on maternal BMI. The program had an excellent impact and process evaluation, which noted that engaging women in discussions about health and nutrition through SHGs was actually quite challenging, mostly because of lack of time. So that's the 10 minutes in a 1-hour meeting focusing on health and nutrition. They also found that supply-side interventions that were meant to happen unfortunately didn't materialize, which caused quite substantial issues. They argued for streamlining the BCC content to have a more narrow focus on fewer outcomes, as well as increasing its reach and quality. And finally, we turned to interventions that did community mobilization with open groups rather than SHGs. In Jharkhand and Orissa, EGJUT and UCL tested the effect of having a new cadre of worker like a second Anganwadi carrying out home visits and participatory group meetings with participatory learning in action to improve children's growth. And the primary outcome was children's linear growth, length for age Z-score. We also measured some secondary maternal nutrition outcomes. So this second worker did home visits in the 3rd trimester of pregnancy, and then monthly in the first 24 months after birth. So you'll note that this is actually a bit more intensive than the HBYC program, which is currently being promoted with ASHAs. In the PLA cycle, groups identified problems and strategies related to maternal and child health and nutrition in the first 1,000 days of life. We found that these activities improved maternal and child dietary diversity and reduced infant mortality, but unfortunately had no effect on children's length for age and no effect on maternal BMI. We hypothesized that the background food insecurity and poor access to healthcare were likely constraining factors for this intervention. So lessons from this study were then taken up by a subsequent program led by Egjut and Nested within a broader initiative led by PHRN, SIMI, Egjut, Chaupal in Chhattisgarh, and IDA in Bihar, with inspiration from the crash program run by Jan Swasth Sahayog in Bilaspur in Chhattisgarh. So the ARM initiative, Action Against Malnutrition, aimed to reduce undernutrition among children under 3, again through monthly PLA meetings, participatory learning in action, home visits, but also in the most underserved areas, creches for young children. So here the comparison was between 3 arms. There was a control arm with only service strengthening, a second arm where there were monthly PLA meetings and home visits, and a third arm, which was the most intensive, where there were PLA meetings, home visits, as well as creches for children aged 6 months to 3 years. So we compared the prevalence of child wasting, underweight, and stunting in all of these 3 areas. And we found that although wasting was reduced quite substantially in the area with PLA and home visits, the most consistent impacts across all indicators of undernutrition, wasting, stunting, and underweight were in the most intensive arm, where there were PLA meetings, home visits, and creches. We did look at some maternal nutrition related outcomes, and we found some increases in care seeking for problems during pregnancy, but we did not measure maternal anthropometry. So if we look at the 7 experimental nutrition studies in our review, and you divide them up into those that found no effects and those that found some positive effects on their primary outcomes, you might think that a lot of group-based interventions can actually improve maternal and child nutrition. Unfortunately, 2 of the 7 studies reported on self-reported behaviors only. And when we look at studies that included anthropometric outcomes, maternal or child, only 2 found positive effects, and these were on child nutritional status. If we look at it further and we exclude studies that were at high risk of bias, as quite a few were, we don't have a single study with groups that shows a positive effect on women's anthropometric outcomes. So before I close this part of the presentation and hand back over to Sapna, I just want to share with you some hot off the press results from a study that will be published in the next 2 weeks, and that was led by my colleague, Professor Sunita Kadiyala, with partners in Digital Green, Varat, Egjut, London School of Hygiene, and JSI Spring. This was the Upavan trial in Orissa, which tested 3 combinations of nutrition-sensitive agriculture interventions with groups. In the first arm, which is called AGRI in this slide, there was dissemination of videos about nutrition-sensitive agriculture to self-help groups on a bi-monthly basis, and then some follow-up visits at women's homes to find out if they had adopted any nutrition-sensitive agriculture practices. In the second arm, SHD members also were exposed to some of these videos on nutrition-sensitive agriculture, but to this was added exposure to nutrition-specific videos about maternal, infant, and young child nutrition in the first 1,000 days of life. And then finally, in the third arm, we have the same nutrition-sensitive agriculture videos and some nutrition-specific videos about maternal, infant, and young child nutrition. And you have participatory learning and action meetings in which groups identify, prioritize, and strategize over problems related to maternal and child nutrition. And here are the results. So we found improvements in child dietary diversity in the arm that had nutrition-specific videos, as well as the arm that had nutrition videos and participatory learning in action, with slightly greater effects in the participatory learning in action arm. Similarly, we found some improvements in maternal dietary diversity across all 3 arms, borderline significant in the agri-nutrition arm, and the strongest improvements, again, in the arm that had both the videos and the participatory learning in action. Also, interestingly, there are no, again, improvements in maternal BMI and no improvements in child wasting. So the picture becomes quite consistent. These group-based interventions can modify maternal and child dietary diversity, but start to run into trouble when it comes to shifting some of these harder anthropometric outcomes. So in summary, we have too few experimental studies with actual maternal nutrition outcomes as primary outcomes. Quite often, maternal nutrition is buried in a set of secondary outcomes, and many studies are actually underpowered to detect changes in maternal nutrition outcomes specifically, which is a real issue with the literature that we can address in the years to come. There is little robust evidence that being in an SHG on its own improves nutrition outcomes. Instead, it seems that additional intervention is required, and some of that has been shown to work in the IKP studies, for example. We know that women and children's dietary diversity are amenable to change through interventions with both SHGs and open groups, or indeed SHGs that open up to non-group members. So this is very encouraging. We also are starting to realize that offering opportunities for social support and collective problem solving works better than just providing information, whether it's through flip charts or videos. Quite clearly, changes in maternal and child anthropometry require concurrent supply-side interventions. And Dr. Kulkarni highlighted this in her opening remarks. And this is no surprise, and it echoes some of the literature from global systematic reviews as well. We know from these systematic reviews that most behavior change interventions to improve IYCF and maternal nutrition still rely too heavily on education-focused techniques. And most reviews have called for studies that look at interventions that increase social support, create enabling physical environments, and improve self-efficacy in problem solving, rather than just providing information. We also know from the global literature that just providing education, here the example is on complementary feeding education, works to shift anthropometric outcomes only in context of good food security. And where we have food insecurity, these education-based interventions are unlikely to have an impact on hard anthropometric indicators. I'll stop here and I'll hand back over to Sapna to talk to us about the characteristics of successful interventions.
Thanks, Audrey. So I'm going to bring us back to what our learnings from the evidence mean for future programs and for future research as well. So next slide, please. So what we emerged with from the review of over or close to 100 studies were 5 common principles that seem to emerge across effective interventions in nutrition, but also across all outcome areas. So the first is that the outcome is appropriate. And what we mean by that, it's an outcome that's either been decided by members in a participatory approach, or the groups themselves open up to women for whom the outcome is relevant. And I'll go into this in a bit more detail in a moment. Similarly, that social and behavior change approaches, as Audrey mentioned, have to go beyond interactive or information transfer, let's say with a flip chart or giving women messages, but rather engaging them within problem solving to identify their own problems and, importantly, their own solutions. And this has been shown to be effective in numerous settings. And also that interventions that strengthen the capacity of the communities or groups, as opposed to, again, just individual behavior change. The third important principle is around quality facilitation. Who is facilitating these group sessions emerge as an absolutely critical point of understanding across the interventions. So women who are local or local health workers, nutrition workers as well. The fourth principle, and I'm going to go into all of these in detail in a moment, was around adequate intensity. So as we've seen across many interventions and across many settings in different outcomes, is that the meetings themselves, and I think everyone in public health recognizes this, that exposure matters, how often you're engaging in the problem solving or in even hearing messages really matters in terms of outcomes. So regular meetings, but also sufficient time dedicated to the topic at hand around health and nutrition. And lastly, population coverage, that enough relevant women are reached, and it's also inclusive of the most vulnerable specific to that nutrition outcome or health outcome. So I'm going to go into detail. Next slide, please, Audrey. So what we mean by the relevant outcome in particular, and this really emerges with the National Rural Livelihood Mission, for example, a recent evaluation that the ministry had commissioned found that the mean age of members is about 38. So it's women well beyond their own childbearing. And of course, they may be mothers-in-law or have other women in the household, but specific to them, the outcome may not be directly relevant. And some of the qualitative work that emerged in process evaluations for those that did conduct them and interviews we'd conducted also, I mean, women articulated this, that, well, my children are, in 11th class, why should I hear about breastfeeding? So although those messages may be diffused, it's important to remember that SHGs in particular, about 2 to 4 members, are probably the specific target group or the most relevant women really for interventions around maternal nutrition. Similarly, in urban areas, a study that Audrey had mentioned that looked at neonatal practices, not enough urban women were interested in learning that information, either because of their own demographics, they had the information, or it just wasn't their top priority. So the importance here really emerges about prioritizing what women want to hear in these groups. The second, in terms of relevant outcomes, in terms of effective interventions, were where the mechanisms had the outcomes had plausible mechanisms. So they're either practices that are independent of supply, or as we saw in the example of providing creches, where there are direct linkages with supply. And this is most prominent and probably most important when it comes to anthropometric outcomes, that food insecurity itself is also addressed, because behavior change can only go so far. And the third is that we found interventions that had too many outcome areas, at least more than 2 areas, didn't have evidence of effect. And this is probably linked to the intensity. I mean, how much can you cover in that monthly meeting, for example? So it's important to be very focused, we learned. So the content itself is tighter, but the implementation itself can be intensive. And this is something, I certainly learned the hard way at SEVA, where we try to address many topics of interest that emerged from women in one trial we ran, for example, but in trying to address malaria, diarrhea, and early hysterectomy, we ended up addressing none of them when it came to measurable outcomes. And that's an important lesson in terms of intensity and focus. Next slide, please. So in terms of facilitators, there was a really wide range of facilitators we found across studies, and generally in 4 categories, either an SHG member herself, a local woman who is hired as a facilitator, which is also quite common in some of the more health-focused interventions, an SHG, either community mobilizer or a CRP or someone within that system, and lastly, someone within the health system, because most of our interventions did look at health outcomes like the ASHA or a local community health worker. Now, there are a great many advantages to each of these models. The SHG member herself, for example, knows members and she can mobilize them. The local woman is obviously local, but also is probably motivated to work on the issue. Someone, again, through the SHG system knows the groups and knows how they function and therefore has that trust and ability, whereas the ASHA, for example, has links to the health system. We did find, though, however, that there were a lot of barriers, particularly to SHG members who may not have had the communication skills or the leadership in order to address the issue. So, for example, an intervention in Bihar that worked on violence against women found the SHG members themselves lacked the communication skills to really address violence, and many of them had the same patriarchal norms that the group was trying to address. With the local woman hired as a facilitator and a health worker, I think the greatest advantages we found was that they could focus on the health issue. But in the case of someone hired from the outside, they didn't have the linkages to the health system to facilitate referrals necessarily, or were not sustainable beyond a point. So what really emerged is that those who focused on health had the time. So in contrast, let's say an SHG community mobilizer, and I think Swabiman's example is very interesting here, because chose to train people at the VO level, for example, at the village organization level, and build capacity, not specifically around health or nutrition, but around conducting participatory meetings, which is an interesting learning. But overall, if we're to look at this kind of map of different types of facilitators, the principles that emerge is that the facilitator should be trusted, motivated, and local, has links to the health system, and also has the ability and, very importantly, the time to be able to prioritize health and isn't juggling, for example, also loans and livelihoods activities and etc., and may not have the time. Next slide, please. So the point to intensity, and this really emerges as an absolutely essential point with groups in particular, when the benefit and the greatest benefit and advantage of group-based programs with existing groups that may have been formed for microfinance, for livelihoods, for social solidarity, is that they're already there, and they're already there at quite a large scale. But they also have other outcomes that they are working on. And as we know, women are busy. They have multiple responsibilities. So what we found when we examined, and along with my colleague Abhishek Hazra at the council and other colleagues, we examined how long women actually met in meetings. And this was based on observations of meetings that were conducted, so mostly direct observations of the meeting as opposed to self-reports. And what we found was you saw a range when it was an existing SHG who was layering on an additional meeting, let's say once a month, for either a year or two, or several of these were 2 years, as you can see to the left of the slide. We found that the maximum that they were able to spend talking specifically about health and nutrition in that monthly meeting was about 30 minutes. And this is based on the studies that we have access to. So this includes studies with Jivika, with the RGMVP, and I know Sampatji is here as well and can speak to that. And I think some of at least the evaluations spoke to the difficulty again in balancing, but also in retaining women's interest. It might not have been, we don't know, it may not have been their topic of interest, or they just may have been very busy and weren't attending meetings for very long, regardless. Now, in contrast to that, the open groups that were formed specifically for health and to work on a health issue tended to draw in women interested in that issue by design. And the meetings tended to be at least an hour or to an hour and a half, at least across the interventions that we have access to, process evaluations. So overall, what this tells us is that intensity is essential, and programming going forward really has to think about what that means in terms of outcomes. We often hear the term light touch, that, can we just do something quickly? But unfortunately, what the results tend to show is, well, doing something quickly will probably translate into equally light results. So the intensity of what actually goes in is critical. And what we found was a dedicated meeting at least once a month was a common principle, a discussion for at least an hour, and also the length of the intervention, the duration, whether it's a year, 2 years, is appropriate to the outcome of interest. And this is also, you'll see not everyone measured this, and for the evaluators and researchers here in the audience, it's also important to ensure we measure this to understand the exposure and the intensity of interventions as they are. And last slide, please, Audrey. So I'm going to leave you here with a summary of findings, and we're very happy to take questions, of course. But overall, across our 100 studies, we found that there's moderate quality evidence that women's groups interventions can have positive effects on women's and child dietary diversity, as well as perinatal practices, such as early and exclusive breastfeeding and neonatal survival. But we know that these improve outcomes if the outcomes are relevant, that the women in the group either have chosen them or they're definitely of their interest, because it's open to anyone to attend. And I think a direct implication of that, of course, is for an existing group to open up to other women in the community, depending on the topic. That the interventions go beyond knowledge transfer and that they're sufficiently intense. So we do know in terms of layering onto pre-existing groups may be effective with behavior modification, but we don't till date have rigorous evidence that hard health outcomes such as mortality or anthropometry have improved. These also require wide coverage of the vulnerable, and to ensure that there's priority for health to improve population level outcomes, we need coverage of the right women across the population. And as we know from the NRLM, there's very wide coverage, but it also varies from state to state. So lastly, to leave you with 3 messages, we know that population level health improvements are possible through groups. if community mobilization is the center of the intervention, which is what we've seen as a kind of emerging theme, but consistent theme, we go beyond thinking of groups as a platform, but actually thinking them as a set of women who can leverage their own skills, their own knowledge through appropriate facilitation and participatory methods to reach more women in the community and the community, and really invest in building capabilities outside of the group, but really to include the whole community if we're interested in improving population level health outcomes. I'm very aware we've thrown a lot of information at you, and I hope for the implementers on the panel, a lot of this probably resonates from your experience implementing. I know it did for me, some of it uncomfortably when I think back to what we tried to pile on to save our members who were busy doing work around labor, who were organizing on multiple issues, and then we throw on health and expect things to change. And somewhat in retrospect or in hindsight, one realizes the principles of intensity, coverage, and really relevance are absolutely critical. And hopefully the next generation of interventions such as Swabiman will show us what happens when we adopt these principles within even the SRLMs, of course. So the paper that this is based on is available in the BMJ Global Health, and we're happy to, of course, circulate it amongst the participants. So at that, again, I thank you very, very much for having Audrey and myself here on behalf of our team, and we look forward to hearing your feedback.
Thank you. Thank you, Dr. Desai and Dr. Prost for the enlightening and engaging presentation. We have understood that community interventions with women's groups can improve women's health and nutrition if they engage with all communities and with sufficient intensity. So we have about 5 minutes to discuss few questions from participants. A question I would like to ask, and this is to both of you. Given Indian women's triple burden of thinness, obesity, micronutrient deficiencies, which type of intervention, a school, club, or a collective, or a combination of all three would be most effective in improving women's nutrition? Could you please elaborate on a few strategies which would specifically help? For example, help us reducing women's anemia. Thank you.
Maybe I can take this one, Sapna, and you can take the next. So our review suggests that collective type interventions are probably the way to go to improve maternal nutrition, but that to shift outcomes like anemia or indeed maternal BMI, you also need concurrent efforts in supply side strengthening and complementary intersectoral interventions. And I think this really speaks to some of the work that Dr. Sethi and colleagues have been doing on Swabiman. Unfortunately, we don't have enough robust evaluations of this collective community mobilization type approach combined with a sufficient effort on the supply side to really show us what that can do for anemia and for maternal BMI. The Upavan trial led by Professor Kadiala, whose findings I was able to share with you earlier on, did not find an effect on maternal anemia or on maternal BMI, interestingly. But yet again, this is an intervention that was a collective and generated demand, but in the absence of a complementary supply side effort. So we really need both to come together and to be evaluated together in future studies.
First, Dr. Wani would like to ask the speakers, are there any nutrition-based livelihoods done in any of these interventions in systematic review? Any results on the outcome?
Can you repeat your question?
Are there any nutrition-based livelihoods done in any of these interventions in the systematic review? Any results on the outcome?
So in the studies that we had found, we didn't find any that focused on a nutrition-based livelihoods intervention. We did see, for example, in the IKP, the the credit line that was specific to rice or to poultry, but there wasn't a specific livelihood. And I think that's a great opportunity. And I believe that's what the Orissa Livelihoods Mission, the OLM, is trying to promote as well. And it'll be interesting to see what emerges there. But till date, no, we haven't. And the livelihoods programs themselves that have been evaluated, as you know, on their own have not had significant effects on nutritional outcomes, particularly anthropometry.
Thank you, Dr. Sapna. Dr. Vani, would you like to ask any other questions to them?
Thank you, Dr. Bharati. I've put in a couple of questions to the presenters. My request if those can be answered. Specifically looking at the systems part, looking at both supplies and demand.
I'm going through your questions, Vani. I'm trying to figure out which one we can tackle first. Any data on value for money and financing leveraging for such interventions and the role of government? So very few studies actually had related cost effectiveness evaluations, which is another significant gap. Sapna, you might be able to say a little bit more about this.
Sure. There were actually, I think, 7 studies that had or maybe it was 8, I think, had cost effectiveness evaluations, but they were very much about the program. And Vani, I think what you're referring to is leveraging either because they're existing groups, and everything that had the cost effectiveness evaluation till date has been specific to starting new groups or pilot interventions. I think the emerging results that we'll see from the scaled up participatory learning and action in Jharkhand will probably have some insights into that, as well as your work with Swabhiman. But till date, in terms of the scaled program, no. There has been cost effectiveness work done to some extent, of course, around the NRLM interventions, but not again specific to these outcomes. We have a lot to evolve, I think, and the research field is now evolving, and we've learned a lot of lessons from seeing these evaluations. And it's important that future evaluations, I think, take on some of these lessons, such as integrating cost effectiveness or value for money.
Dr. Vani also asked about preconception interventions with women's groups in slums. We did not find any such interventions, Dr. Vani. It's a gap. But clearly interventions with open women's groups or with self-help groups in urban settings face considerable challenges, and this was reported across all of the urban evaluations. There are challenges linked to time, there are challenges linked to women being extremely busy with their livelihoods and not necessarily, for example, in the case of the studies in Mumbai, even having time to meet or a shared language to be able to mobilize together as a group. So there seem to be quite strong limitations to working with groups in urban settings, let alone informal settlements. I'm trying to get to your question on systems, but I can't see it.
Vani, you can say it again. That's easier. And in the meantime, I see another question from Purnima Menon around tracking social determinants of nutrition outcomes. Audrey, why don't you take that in terms of the social determinants approach?
Yes, that's a really interesting question. So several studies have looked at early marriage and prevention of early pregnancy, but they look at it as one of many, many different outcomes. And one of the problems we often see with groups is that overload of topics and issues that are thrown at the groups, either for problem solving or just as messages to encourage healthy practices. So there are some studies on that. They haven't measured these as outcomes, so they haven't actually measured any changes at age of marriage. But the big issue is just overloading nutrition interventions with too many other concerns and too many other determinants that are intractable for groups in the short term. This comes back to something Nita ma'am was saying, I think, in her opening remarks about giving these interventions, if they're going to tackle these social determinants, enough time to actually bed in and have an effect. You can't, I don't know if it's realistic to expect women's groups to reduce the age of marriage within the 3-year typical time frame of a randomized control trial. So this is, I mean, there are two issues, both the overloading of groups and the time frame within which we can expect to see effects on these outcomes. I don't know if that answers your questions, Purnima.
Thank you, Dr. Prost. I think we'll have to stop here. Any further questions which are posted at Q&A, our panelists will try to answer them. So let's move to the next second part of today's program, that is the panel discussion on the role of women's groups on maternal health and nutrition. It's my great privilege to introduce Dr. Rashmi Amla, who will be moderating the discussion. Dr. Rashmi is a senior research staff in Poverty, Health and Nutrition Division at International Food Policy Research Institute, IFPRI, Delhi. She holds an MS in Nutrition and PhD in Health Promotion, Education and Behavior from the University of South Carolina, Columbia, USA. Her research focuses on understanding processes and determinants that influence program implementation and their impact on nutrition. As part of her work under Portion, she synthesizes and generates evidence to inform policy and programmatic decisions aimed at improving maternal and child nutrition. Over to you, Dr. Rashmi.
Thank you, Rajni. Welcome, everyone. And after this very enlightening presentation from Sapna and Audrey on the evidence around the women's groups and collectives, I would like to now invite our 5 panelists who bring in different perspectives from the world of implementation and as well as policies and programming, and also practitioner view from as a medical practitioner. So I have the privilege to invite Dr. Sanjay Kumar. He's the Indian Country Director of the Mittal South Asia Institute at Harvard University. He holds a PhD in political science from JNU and a master's in public administration and public policy from Harvard Kennedy School. He has previously worked in Seva Bharat for 17 years and held different several leadership positions. Now I will continue to introduce all the panelists at once, and then we'll have time to speak with each of them. Next is Srimati Madhu Ketan. Madhu is the program director at Pradhan, which stands for Professional Assistance for Development Action. Pradhan works in the poorest regions of India and organizes collectives that help people, especially women, earn a decent living and support their families. Madhu is a development professional who has worked at Pradhan for close to 30 years, and she is recognized for her pioneering work on gender equality through women's collectives in Pradhan, as well as for her work on institution building and farm-based livelihoods. Great to have you, Madhu.
Thank you.
Next, I would like to invite Mr. Saurav Bhattacharjee. Saurav is a nutrition specialist with UNICEF Odisha. He is an expert in maternal and child nutrition with 20 years of multi-sectoral experience in influencing policies, driving implementation, conducting monitoring and evaluation of large-scale programs for UNICEF, CARE, and other government agencies. He holds a postgraduate degree in rural development and public health nutrition and has completed his senior management program from the Indian Institute of Management, Kolkata. And I'd like to next invite Shri Sampath Kumarji, who is the Principal Secretary with the Government of Meghalaya. He holds Masters in Public Administration and Management from Harvard University. He's considered as a champion of field-level leadership in Meghalaya. He previously worked as a project director for Women's Empowerment and Poverty Alleviation at Rajiv Gandhi Foundation, and he has developed a rights-based poverty reduction and community empowerment model at RGMBP. And finally, I would like to invite Dr. Hema Divakar. Dr. Divakar is a leading medical professional in India with a vision to improve the healthcare services ecosystem for the welfare of women. She is the medical director of Divakar's Specialty Hospital. She's a senior consultant obstetrician gynecologist with over 3 decades of experience and expertise in women's healthcare and an advocate for delivery, quality healthcare, and capacity building. She is the vice chair for FIGO PNCD committee and a member of the technical advisory group for Ministry of Health and Family Welfare, Government of India. So a warm welcome to all the panelists. So what we have done is we have posed questions for all of our panelists to share their experience with us in how they have integrated health and nutrition interventions into the group-based platforms they are working in. So we have asked them to particularly comment around the primary motivation for the group formation, what are the components of the health and nutrition interventions introduced, and who drives the implementation within the group setting. We wanted to understand the factors that facilitated in layering the health and nutrition interventions, barriers to implementing these, and if they could finally give us takeaways on looking ahead, what can be improved to leverage the strength of the existing group-based platforms. Having heard the elements of importance from Sapna and Audrey, if our panelists can bring in the flavors from their own platforms and experience and address these questions, that will be great. Each panelist has about 7 to 8 minutes. And then we'll have a chance to ask questions to them again. Audience, please continue to post your questions in the Q&A box and we can direct questions to each of the panelists. So now I'll turn the floor to our first panelist, Dr. Sanjay Kumar. Over to you.
Okay, thank you, Smi, and thanks to the organizing team for giving me this opportunity. You know, it's been a long time since I spoke or I shared my views with such groups, so it's really fascinating. And I heard Sapna Ben's and Audrey's presentation very carefully, and it was very well done research, and you know, I could relate some of the things what they presented from my past experience. So you know, to begin with, as they also said about the SHG and the attention span of like women in the group. So I share a similar view on this, and I don't know, means I have written down a few points which I would like to share. First, to begin with that, when we need to go back to the history of SHG and why SHGs were created. When it was started from like in 90s, it was started with Mairada, a Karnataka-based organization, and it was primarily a microfinance group. You know, SHGs are supposed to be microfinance groups, but eventually, you know, they were loaded with so many things, so many expectations, and I think one of the primary reason why it fails in meeting the expectation is that there are too many programs of government or NGOs, like they need to bear on them in terms of implementation, while they are primarily, you know, microfinance groups, and they are supposed to self-help themselves in terms of saving money, small amount of money, and you know, like rotating that money whatever they save. But then a lot of things kept coming to them, and so I feel that there's too much going on around SHG, and why, you know, and I also want to pose a question that why SHGs are expected to end all social issues, including nutrition, you know, if they are primarily a microfinance group. So if they are made out of this objective, if they are, you know, like developed with this objective that they would also take care of nutrition and many other things, then it is fine. But otherwise, you know, I think there's too much being expected from them. And what they presented in the finding, that you know, the average time they sit for half an hour. In urban areas, you also find that, you know, they don't sit that long because of the time issue and many other things. So, and the next thing I would like to share few experiences from my Seva days, that we experimented in two cases, one in Delhi and one in Madhya Pradesh. And it was a cash transfers. In Madhya Pradesh, we did that experiment with UNICEF, and in Delhi, it was with Delhi government. And it was a direct cash transfers. In Madhya Pradesh, it was like in terms of they were getting cash for other social benefits, and in Delhi it was against their like whatever they were getting in the ration shop. And in both the experiments, what we found that women, and the money was obviously going to women's account, and in both the experiments we found that women were like buying more nutritious food for themselves and for the family. So I think that those kind of experiments we need to take up more in our country, because and we had also recommended through those experiments that why can't they have, the poor families can have choice like between ration and between cash. So those who want ration can continue with ration, because there were two type of groups at that point of time. But I think that did not continue, and that is something which we should definitely explore. And then also we also need to innovate in this sector in terms of working with the groups, working in the nutrition based intervention. When we are working with groups, and how we can innovate, I don't know, I don't have a clear idea, but maybe use of technology in the coming times, and how to use technology for trainings, etc. And there might be some experiments also. But nutrition is a quite individual thing, and I feel that taking it to the group is a good idea. And I was like, we have been hearing about Swabhiman, and that could be a very interesting thing. But I feel that how we can also reach out to individual women in terms of like not only to the groups, but as a follow-up or as subsequent effort to individuals. So, and using technology, that is something very path-breaking and interesting. And also we have been focusing a lot through these groups on women. Why can't we also think of including men in these conversations through mixed groups, maybe, so, and bringing them into the discussion. And lastly, I would also like to say that maybe we should also think of starting things early, and at college level or with adolescent, if we can start the conversation, or if we make groups of young girls in the villages, and then we talk about nutrition, and not only nutrition but many health related issues that they become aware of, and then they take care of themselves when they become mother. So that is a conversation we should start early. I feel that in India we focus less on early years, and then we, as a result, as an effect, we need to we don't have any option other than in making intervention at later stage. So why can't we have conversation or groups of young girls in the schools, high schools, and in the colleges? So these are some of my thoughts related to the groups, and how we can bring some change in the groups. And also, if there is any specific question, I'm happy to answer. And then, yeah, thank you.
Thank you, Dr. Sanjay. Now, I think we can hold the questions until the end of all the panelists are finished with their remarks. Please continue to post your questions in the Q&A box. Now I would like to invite Madhu to give her remarks, please. Madhu, over to you.
Yeah, thanks, Rashmi, and thanks to NIN for inviting me for the panel. I'll talk about Pradhan's experience of layering health and nutrition interventions on the SHG platform. Before I do that, probably a bit of a background about Pradhan. So we work with around 8 lakh women organized into around 63,000 SHGs across 104 blocks and 32 districts across the 7 states of Central Indian Tribal region. We've been primarily focused on enhancing women's agency through mobilizing them into groups. And our core belief was that if you improve economic outcomes, other things communities are able to move on their own. This belief has, of course, gone through many shifts during the course of the last 30 years. And our work with collectives has been mainly with forming self-help groups around savings and credit. We gradually, very quickly, actually realized that unlike the southern states in areas of stubborn poverty, it takes more than credit to improve livelihoods. So within livelihoods, since the context where we worked was that, you know, almost everyone has land in a tribal kind of a setting, we focused on improving crop productivity and crop diversification. Over time, we realized that, you know, even in areas of surplus production, there was significant, you know, situation prevalence of malnourishment. We therefore embarked upon a pilot to integrate health interventions on top of the, you know, SHG program. And this pilot was also accompanied by a rigorous research called WINGS, women-driven, women improving nutrition through group-based strategies, in which Rashmi and I also see, you know, many other colleagues from IFPRI here who were involved in that. So I'll talk about both the program as well as the WINGS research. I'll also talk about the overall shifts also in nutrition and diet diversity as part of Pradhan's larger mandate of integrating a perspective of nutrition in the overall agriculture program, since this phenomena was also happening in parallel to a very intensive nutrition pilot, which was happening only in certain blocks. So I will, do I have permission to share? Yes. Is this visible? So I think
Yes, it is. And could you put it on the slideshow mode? We can see.
Yes. So I don't want to take a lot of time because this can be very time consuming, but I'll put it on slide share. But see, basically there was this research which showed that the primary outcome that we were aiming for were women's BMI and dietary diversity. And the major strategy which was adopted in this intervention, which was spread across 8 blocks out of the 104 in which Pradhan works, was mainly focused on behavior change communication. Now, listening to, you know, I mean, Sapna and Audrey's presentation, I could, you know, relate so much. And I was only thinking that, you know, I mean, had we kind of paid more heed to the frequent, you know, nudges that we kind of receive from IFPRI, and also the larger, you know, the world of research. So probably, I mean, so, but I'll come to those reflections later. Basically, there were these 4 pathways that we had adopted across the program, and also more generally in Pradhan. So the research over this period does show, and which is a very sobering, you know, sobering results, that there have been very limited, I'll just quickly move on to. So there is, I mean, this kind of threw up, results that there was very limited evidence on the impact of groups on the nutrition outcomes. I mean, we had a three-arm strategy where there were some nutrition intensive arms, the standard blocks, and the control blocks. So differences between this were not very significant. I will not go into the details of this. I will go into another program, which was a larger program within which the nutrition was a subcomponent. The larger program was focused around improving incomes through an intensive agriculture pathway. And within this larger pathway also, we had over the last 3-4 years of the program, an intensive integration of the nutrition perspective into the agriculture pathway. Now, if we look at this program, we see that, it showed, even though areas wherein we did not take a very intensive understanding of nutrition work with the communities, there were significant shifts observed in diet diversity across the, this program was spread across a large number of Pradhan blocks, covering more than 70, 80 blocks. So at the same time, these programs were more or less, happening simultaneously in time. So I'll stop here. I will not go into the details of this and stop sharing. Yes. So basically, my own reflections on this is, one is, the questions that the speaker before me, Sanjay, said. One is, there are, of course, reflections around how we could have done the layering much better. My reflection in that is that, there are limits to what a BCC heavy or BCC alone may achieve, because there are, I mean, as we all know, and research by Sapna, etc. also, I mean, there are limitations to what, how much a BCC will translate into action. And of course, there are all the other reflections around tailoring the messages, the intensity of the messages, and also coupling it also with other kinds of supply side interventions, like the peer groups, the home visits, etc. So of course, these are all reflections on the way we could have probably packaged the whole intervention much better, and we can. But the other thing, the question that Sanjay also raised, and this question is very, in front of me, that, groups which are primarily formed by the women around the purpose of improving something which is in their private space, improving their well-being, improving their access to affordable finance, improving their incomes, etc. Now, how much of a private agenda can you actually integrate into, because, we do understand that health and nutrition is a public good. Now, how much of that do you expect women's unpaid labor to actually, do you want to rest it only on that? So we do have to couple it with more supply side interventions. Those supply side interventions could possibly piggyback on the existing mobilization of women's groups. Also understanding that when we say women, it actually hides more than it reveals. So there are, I mean, although the average age may be 38, but it's actually, if you look at the range of women, there may be women right from 18, 20 to actually women who are close to, 60, 70. And each of these women, the aspirations, as we are realizing in a very recent program that we are doing with a multi-sectoral program with UN Women Support, the aspirations of each of these categories of women is so different. So actually you cannot really homogenize. And as Sapna was also saying, that a woman, whose kind of a son is in class 11, so what relevance is this? So all those questions are also there. I think I'll stop here. I'm also conscious of the time, and happy to take any questions later. Thank you. Over to you, Rashmi.
Thank you, Madhu. Thank you for those thoughts. And we'll get back to you with questions. I see there are questions coming up in the box. Now, I'd like to invite Saurav Bhattacharjee to talk about the mission that he is associated with.
Yep. Thank you, Rashmi. May I request that the presentation? Yeah, thank you. So what I've done is I have basically formulated my thoughts and put it in front of you as a presentation, which will basically allow you to see how the entire chain of thoughts which is in my mind. And I'm joined here by Dr. Vani, who together we kind of co-created, co-conceptualized the Swabhiman initiative. Neeta ma'am is here, so we have been taking her advice off and on. So basically I'll be talking about while this program is being run currently in 3 states of India, 3 vulnerable states with large proportion of vulnerable population. I would focus my discussion mainly on the state of Odisha, which is an eastern state with around 23% tribal population, thus making all of us realize that we cannot achieve C-square IQ, that is coverage, continuity, intensity, quality at scale until and unless we address the needs of the most vulnerable tribal groups. Next, please. Next, please. Yeah. So this is something which all of us know. Is poor women's nutrition, which is about poor height, thinness, chronic energy deficiency, BMI, anemia. It impacts not only maternal mortality, but overall health, productivity, earning and decision-making capacity, family and childcare. Thus, it is utmost importance that we discuss about women's health and nutrition, not just about women's health and nutrition in the context of their reproductive rights. Poor women's nutrition leads to maternal undernutrition. It impairs fetal development if the woman at all decides to marry and get into childbearing. It contributes to low birth weight and increases the risk of stunting. All of us know that fetal stunting is visible almost 14 weeks in utero. And the burden of low birth weight is very high in India, which is around 21.4%. In Odisha, it is more than this. So all of us in Odisha, we need to pay a lot of attention to addressing nutrition for women. And age at marriage, all these are factors which actually lead to poor women's nutrition, early age at marriage and early childbearing, anemia, specifically in Odisha, the iron deficiency anemia is of primary concern. And we know that low birth weight, this is something which I have already mentioned, that low birth weight and childhood stunting are also high. It is reducing. Nevertheless, we need to accelerate our efforts to be able to achieve the reductions as envisaged in the SDGs. Next, please. Now, there was this question, why should women's groups be burdened with an additional responsibility of looking at health and nutrition? We probably conceptualize Swabhiman so that the women's collectives themselves, because they are meeting, anyways they would be meeting. So how do they discuss about their own health and nutrition? Women who are into productive activities, how do they also look at their own health and nutrition? And women collectives have shown the way through National Rural Livelihoods Mission, when they have moved from the Pancha Sutras to the Dasha Sutras, and health, education, gender, layering gender, all these have become of utmost importance. All these have been layered into, because they have moved from just being a financial institution to being a more inclusive development institution. What have been some of the enablers? How have collectives shown the way? Strong political commitment and leadership. In Odisha, we have ample of those, and in also the states which are implementing Swabhiman, we have seen ample measures of political commitment and leadership. There is a strong institutional mechanism, as Madhuji ahead of me was mentioning, focus from institution to household to individual well-being, strong community cadre and exposure of members, capacity, because we all of us have seen these self-help groups are really the decision pockets in the village. And we have seen groups in remote Koraput district, which is a tribal district, actually have gone ahead and asked the asked the BDO to be sanctioned either an Anganwadi center or taken up contracts to constructing individual household toilets and latrines and ensuring that communities use them. Self-driven and motivated, yes, they are. Community support, convergent action, and establishing FNHW as an enterprise. So FNHW is food, nutrition, health, and wash. And I will come very soon as to how we are looking at these intervention in Odisha. Some of the barriers, yes, this is also not only prevalent only among the grassroots, but also among some very seasoned thinkers who do not really think that health and nutrition are really our priority over livelihoods when it comes to self-help groups. Sensitization of the system, how the self-help groups can actually play a key leverage role in improving the health and nutrition of their own cadres and of the community in general. Low incentives, yes, still now the nutrition counseling, because what the nutrition we are talking about, yes, it has supply components, but majorly is behavior change interventions. And we feel that behavior change, still many of us consider that behavior change interventions should be a kind of a voluntary service, which it should not be. Livelihood related options, whether there are nutri-based livelihoods. And in COVID-19, during this time, it is now more than a year that we are kind of moving in and out of the difficult situation. So engagement in other work, because the self-help groups have been burdened under the Special Relief Commissioner's advice. They have been burdened with providing ration, providing hot meals, hot cooked meals for the temporary migrant camps and all those things. So with this idea of improving women's nutrition, mainly to look at the self-help groups, we designed this, co-created this program along with the government called Swabhiman, which the geographic scope, it was in 3 states. In Odisha, we initiated as a pilot initiative in 2 blocks of Odisha, and then over a period of time, we have scaled it up across 3 districts, but mainly in the intensive programming areas of the State Rural Livelihoods Mission, with the rationale of improving food and nutrient intake, improving micronutrient deficiencies and anemia, increasing access to VHSND and special care to nutritional at risk, improving WASH, because that is one of the key nutrition sensitive interventions, prevent early poorly spaced or unwanted pregnancies. And what we use, we basically work with the cadre, the frontline cadres of the State Rural Livelihoods Mission, who are called the community resource persons. We call them the Poshan Sakhis, and we engage with the village organizations and the cluster level federations. So it would be of interest to know that the primary groups that we are working with are adolescent girls. Yes, thus we start early in our intervention, newlywed couples, pregnant women, mothers of under 2, and very recently in this year, we have started working with men and boys as our primary group, because we know that improving nutrition for women should not only be the responsibility of women and girls. Secondary, family members, particularly husbands. Last please, previous slide please. And the duty bearers at the community level, which are the AAAs. So how do self-help groups engage with Anganwadi workers, ASHA and the ANM to be able to improve the nutrition supplies at the community levels? Next. Next please. Next please. Okay, so the approach is basically, it is a mix of systems actions and community level actions, and thus Swabhiman interventions like Swabhiman, we try to layer it or integrate it in the most hard to reach areas where the system's capacity is generally weak. So the community groups, the self-help groups actually act as a link between the community service providers, act as convening platforms to ensure that the most vulnerable populations are reached. And some of the key community actions are food, health, nutrition, wash, microplanning, which is on the similar lines as the mother child protection card. It is spread over 12 days, spread over 2 months, wherein communities basically sit and they look at their problems, they prioritize their problems, they discuss among themselves and with their service providers to draw up a convergent action plan. And then based on this action plan, they receive funds for implementation of some of those action plans from the vulnerability reduction fund of the through the cluster level federations. Next, please. Next. Okay, so what are some of the cluster level federation activities? So you would be getting a clear cut idea on what exactly is being done. So we have some monthly activities, we have some quarterly activities, biannual activities, and annual activities. So basically it is about the monthly activities. Some of the important ones are how do you link nutrition based livelihoods to the nutritionally identified families with nutritional vulnerabilities, women who are nutritionally vulnerable. Then quarterly meetings like participate in the block convergent reviews, trainings of the community resource persons, the Poshan Sakhis and the village resource pool. The vulnerability reduction, using the vulnerability reduction funds. Biannual are newlywed couple meet and women entitlement camps and checkups. And annual would be the lead the preparation and the stock taking of the FNHW micro plan. And some of the village organizations. So these are the cluster level federation led activities. Some of the village organization led activities include selection of the cluster resource, the community resource person or the Poshan Sakhi, then forming of the adolescent girls group and their fortnightly meetings. Then what does the Poshan Sakhi or the community resource person does at the village level, including conducting Maitri Baithaks or discussion with mothers on some of the various health, nutrition and wash issues which are being faced by them. Then VRP is basically the monthly Maitri Kishan Baithak. So basically there's a farmers group meeting also, which looks at linking up agricultural options to nutri-based nutrition, basically linking the farm to the field. And at the SHG mobilizing for VHSND services and washing hands as a practice. Next, please. And as I say, we basically have we have seen how there has been improvement. And if we look at Odisha, we have seen over the baseline to the end to the midline, the end line is currently being conducted. We have seen increase in access. We have increased better. We have looked at and found better services being delivered. For example, ICDS entitlements, access to PDS have actually increased. Intake of animal proteins have increased. Knowledge on family planning, spacing between pregnancies, these have increased. And for mothers of children under 2, you can see receiving ANC in the first trimester. And trust me, these services are being provided in the VHSND, Village Health Sanitation Nutrition Days, which is one of the key areas where the Poshan Sakhi or the CRPs, the SHGs are actually converging with the triple A's, which provide the health and nutrition services from the other departments. Next, please. So what is the way forward? And you would see that some of the points that my earlier speakers were mentioning, we have tried to actually address many of those points in our way forward. Next, please. So nutri-centric livelihoods promotion, we are looking at backyard kitchen garden. We are looking at nutrition as an enterprise, shed net nursery. So backyard poultry through the livelihoods mission is being promoted for both egg and meat purpose. Goat rearing, leveraging vegetable mini kits from the horticulture department. So this is about a strong convergence with other departments. Nursery raising, both for individuals as well as commercial activities. Then nursery vermicomposting pits, fencing in convergence with the AMNREGS, so that actually increases and enhances the earning capacities of those group members. And some SHG run enterprises, mainly THR preparation, some of those groups are involved in THR making and closely linked with the women and child development and mission shakti groups, food enterprises, sanitary napkin units. We have had examples, small shops for grocery, vegetable and other items, mask stitching. This has been one of the major earning source for the SHG group members during the COVID days. Sanitation motivators, so SHG run canteens. So as I was mentioning, the Special Relief Commissioner's grant was used and provided to the SHGs to run food canteens for the and home delivery for the migrants who returned to Odisha during the COVID time. And they have also been functioning. So we have a very close convergence with the rural development and the RWSS department, and as sanitation motivators, toilet construction, sanitary marts. So they are being engaged. And we have proposed how do we use the solid liquid based management enterprise as as a key earning as well as important intervention for Swabhiman. Access to finance, facilitating credit linkage, introducing new financial products, and then we have loan restructuring like moratorium period, creating own loan products by SRLM and other organizations, awareness and support services, training and awareness on social distancing. This is one of the most critical things that we did through the livelihoods mission during COVID in terms of the health and nutrition messages which needs to be provided to the communities during the COVID, coordination with the AAAs, which is ASHA, Anganwadi worker and ANM, availability of counseling services and referral, regular networking and follow-up using SHG networks, ICT-based training to women. And we have used a technical intervention which we call pico projectors. When we go to the villages, especially in the remote areas, this pico projector has actually acted as a technical innovation wherein which have been used to provide and give key messages to the communities, either facilitate group discussions or while going to individual households. And then mobile phone enabled training and awareness material. This is already I have mentioned. This is some of the resources that we have used. We have adopted from other states and used and modified the content as per the state's context. Next, please. Thank you.
Thank you, Saurabh. Thanks. That was a very comprehensive view of the Swabhiman program. Now, I would like to now invite Shri Sampat Kumarji to comment on having heard the evidence review and the implementation experiences. If you could bring in put on your hat as a government, from a government perspective, if you could share some of your thoughts on women's collectives and how they can be leveraged to improve health and nutrition of women and children.
Thank you, Dr. Rashmi. Thank you, the organizers, UNICEF and NIN. I would like to, it's great to see the presentation by Dr. Sapna Desai and Dr. Audrey. In fact, a lot of evidence. In fact, I'm also closely connected with some of the work that has been done in UP as part of Uttar Pradesh Community Mobilization Project, which is implemented in partnership with GAIDS and RGMEP and other organization. Population Council was the research organization. So it's a pretty, in fact, it's very nice to see that data. I think it's a great insights. I think I really thank and appreciate the researchers. In fact, both Dr. Sapna and Dr. Audrey. And I also very nice to see, especially the Swabhiman presentation and the presentation from the previous panelists. Great to see and learn about their insights. I would like to give, as you said, I think I worked in Andhra Pradesh with IKP, and I worked in UP, and now I'm working in Meghalaya. I can actually just give the perspective from both supply and demand side. While working in UP, I was working outside the government. So, so that's like how, in fact, especially in a very resource poor areas, very backward, blocks of UP. In fact, the experiment that was done, which was shown in the presentation about the UPCMP, was implemented in 200 most backward blocks of UP. So one of the assumptions, in fact, this is again a lot of one of the assumptions that what we had when we were doing that work was when you have these, when you are working in a very remote and resource poor areas, and very backward, in terms of different barriers, gender, feudal, and other barriers. What we felt was that I think the demand side, the problem is a more of a demand side problem. You really required to mobilize communities to bring that demand side interventions. So we have taken this beautiful Gandhian model of self-help groups, because it's a beautiful model, where you can, in a very non-violent way, you are trying to address problems by yourself. It's a kind of it's a beautiful moment. So when we started working with that spirit, I think it really started working well. In fact, the data shows, especially in fact, if you go to the granular data of what was shown by the Dr. Sapna, and so what it shows is that wherever there is not much involvement of the supply side interventions, where the services are provided by the service providers, like different agencies. So there, I think the difference, the change is not very significant, but the change is very significant in the self-help box. So we have, in fact, we have divided into the entire the interventions into two boxes. One is the self-help box, another is the entitlement box. So self-help box, when where their ability to protect children, like Dr. Vishwajit, the study, sugar study kind of. So when they adopted this kangaroo mother care, skin to skin care, very significantly. In fact, the change was very significant, because and they found it's a very, in fact, very effective, and they can do by themselves. They don't require much support. Like, when it comes to IFA tablet consumption, it's tough, because again, it depends on the supply side interventions. So like that, so basically, but one of the things what we have seen is that, especially in the resource poor areas, it is, it is the self-help box is a bigger box. I think that way the women collectives can play a very, very effective role. I think that's something that we can see that even in context of Meghalaya, where I'm now working. So in Meghalaya, again, coming back, like I've come to Meghalaya, and I was Principal Secretary, Community and Rural Development Department for last over 5 years. And also for last more than a year, I also have been in charge of the Health and Family Welfare Department, and also the WCD. So basically, I'm when for last 1 year, what we started doing is that how to actually connect this, the supply with the demand. So we have been doing interesting work here. So I just to give one example, in the Poshan Abhiyan, like there is in the month of September, during the COVID period, we have identified about 25,000 SAM and MAM children, severely acute malnourished children and moderate children. So what we have done was, again, we brought everyone together. It was not that like only ICDS working on this. In fact, again, bringing the women self-help groups, and then bringing the entire communities, and so that convergence, when the state, if it can actually convene, and if it can actually mobilize all the resources, and then and generating the demand through the women self-help groups, so there's a beautiful connection what we could see. In fact, over 93% of them were recovered in a span of about 4 months. So that's again a good example of, like, where if the supply side interventions and the demand side interventions, if they work together in a collaborative way, it will have a greater significance. So again, coming back from again, what I mentioned. So one of the things, how actually we can, bring this, I also said entitlement box, how actually we can improve this entitlement box. It should not be, a kind of a, it should not depend on the benevolence or, of, the system that is working. So that's why the entitlement box, to really, address that entitlement box, what we did in Meghalaya, again, we brought a social audit act. It's again a maybe first of its kind act, which actually now which mandates all these developmental departments, around 11 departments in the developmental departments in the state. They are actually, it's mandated that, like, they have to give this information and go to the village to village, and then tell about, like, these are your entitlements. If they don't have, if they have not accessed these entitlements, they, in fact, there is a process to apply, register for these entitlements, and there is a process of public hearing, and and also basically submission of an action taken report. So we brought again a systemic an intervention where you can actually even we can address the supply side problems through an approach and enabling legislation. That's a social audit legislation. So that's why I think we that's one thing that we found. And in addition to that, we also brought a state health policy. So again, I request all of you to read our state health policy, which actually we brought during this COVID period. In fact, and the state, health is a state subject. We in fact, we didn't have a policy before. So we in fact, it is again, it's designed by, if you look at that, the state health policy, one of the model that, to implement that state health policy, one of the mechanisms that we have brought out is that we are calling it a decentralized catalytic leadership, framework. So what does that mean? Like, basically, we really require to bring that collaboration, at a block level, at a public, public health, primary health center levels. So the idea is that, bringing the BDOs, bringing the CDPOs, bringing the medical officers together, and when they keep working together, from the supply side for providing the services to the people, and from the demand side, we have this systematic network of self-help groups which are constructed under an RLM. So systematic network. So those women self-help groups would actually will basically able to access those services with much more efficiently, and also with much more a sense of empowerment. Basically that's something that we have built, that a policy intervention was brought in, and we are working on those lines. And currently we are working on how to reduce maternal deaths. In fact, our maternal mortality rate is one of the highest in the country. So we basically, this is again how to, we launched a rescue mission again with this decentralized catalytic leadership framework, and having a weekly check-ins, how actually each one is taking what kind of an action, and identifying each of the high risk pregnant mothers. So it's a what we are doing, we are using extensively the data technology. At the same time, we are using a community mobilization platforms. And third, very important thing is that leadership. How actually we are using that entire decentralized leadership framework. Yeah. So that's actually briefly just I wanted to share. Thank you for inviting. In fact, I started working with UNICEF in UP, so that was the connection why I was invited for this. Thank you.
Thank you, Sampatji. Thank you for your very thoughtful remarks on that. And now I would like to invite Dr. Divakar. And if you could please reflect on, based on your clinical experience, what are some challenges that you think that pregnant and nursing mothers can face that could potentially benefit from group-based interventions? And what are some opportunities in a clinical setting for some of the group-based initiatives? Thank you. Over to you, everyone.
Namaskar. Thank you, Rashmi. And thanks to the organizers, including mainly Vani from UNICEF, who has been the integral force in unifying all of us, breaking the silos, and we are on a common platform. It is, of course, my role to move out of not only our ivory towers in private practice, but also in our community of the specialist OBGYNs and the whole teams of healthcare providers that we deal with through our organization, FOXY, to do much more than what we have been doing until now. So my heartiest congratulations to so many of the groups who are working very intensely for the nutritional aspect of health, and if with the philosophy of connect and collaborate, if we as professionals can also lend a helping hand, then the saying, together we can, actually will turn our dreams into reality. Well, as all of you, we believe that women's health is nation's wealth. So no matter which age group, some said start in adolescence. Yes, that's a fine point to start, because before she embarks into pregnancy, we want her in the pink of health. Then the target group, which is largely available to us as clinicians, of course, is the pregnancy group with all its inbuilt complications in most parts of the country. And then beyond pregnancy, the postpartum, where many of the pregnancy complications forever and forever lead to the NCDs, a tsunami in the generation next as well. So giving a wholesome importance to nutrition right across her journey throughout her age groups, the women themselves, now it was said that the demand generation, so the women themselves who eat the last and who eat the least should recognize that their health is so crucial and so important for everything that they do. If they are in the self-help group, if they are in the microfinance, if they are going to be productive beyond reproduction, for every aspect, that they are the key, and the nutrition is the base. So what opportunity do we have as clinicians? Well, to confess, really the nutrition aspect of it, we just see through that in clinical practice. We have been given a very standardized guideline by our own government, bringing to our notice that 1 in 5 women is underweight. The prevalence of overweight is also obviously increasing. Every other woman is anemic, and just a very smart, quick checklist of what we are to document on every pregnancy at her visit, whether she's short, whether she's young, whether she's a low BMI, even the height weight record, it's not really documented in the way that it should. And many do not know what MUAC, the mid upper arm circumference. Many of the clinicians and healthcare providers in practice cannot even relate to that term. And of course, the new tsunami of the gestational weight gain and not being able to reduce it as in the postpartum period, and a number of allied interferences, both with absorption of the nutrients that they would take, or the medication that they would take, or the health parameters which are affected and implicated with a series of what is listed on to the corner of this slide. So what do OBGYNs do? The reality bites, because generalized diet counseling is there. It's not contextualized. It's just in general, okay, eat well. Then families also ask doctor what she should eat, because in pregnancy, no matter how she's taken care of in the other parts of her life, but in pregnancy, she's really pampered and made to eat for two, because every attention is diverted to the new life which is going to be joining into the family. Most often we focus only on anemia and some cash transfers where the take-home ration, etc. We are not so much in sync with whatever else is happening. And the counseling is not a systematic service at all, because as you see in the last line here, we are more focused on prescription rather than the diet advice, and general, advice is given, and therefore the capacity building of both the specialists and the whole teams of healthcare providers in any unit, public or private, so that each one teach one principle should work well. And oftentimes when we have tapped the information from the gynecologist, they say the gestational diabetes is becoming a huge issue now, and they're all sensitized to it. That so only when the sugars are high in pregnancy, they start taking their brain onto some kind of specific nutritional advice that they have to give them. As I said before, seldom the height, weight, BMI calculation is noted. Worse still is nobody is tracking the weight gain of that patient. Even if she's severely undernourished or obese, the month-on-month visit, even if she comes for least number of visits or maximum number of visits, attention to the weight column is not really paid, and that is the truth of the matter. So in collaboration with Vigo, the e-dialogues that we first kickstarted has now evolved into this series of programs. But I must confess that out of 40,000 OBGYNs, there's just a handful of us who are at the moment sensitized and paying attention to this. But we know that, yes, if the demand is generated, then the supply side, as in every healthcare provider in the chain, should be sensitized as to what should be said, how it should be said, and how it should translate into their behavior change to get some impact. So everywhere we are now emphasizing the 1,000-day window of opportunity, with good maternal nutrition being the best start in life. And I think we are slowly beginning to get there. And then much was talked about the technology. Let's absolutely not underestimate our girls and women. Facebook, Instagram, WhatsApp, YouTube, video consultations, consulting the lactation consultant from our unit, right from interiors of the country on the video call, with some people wanting to know about the milk bank. So they are kind of very eager to ask. Sometimes language becomes a barrier, because there are many girls and women out there who want of course the counseling in their own language for them to understand better. So this is very much a part of the new normal, escalated because of the COVID-19 pandemic. But there is a huge opportunity for us to give out the uniform messages, sharing, and make a good use of the waiting time, both in the public and private sectors, and telling them to eat right. The challenges are around the lack of information and several misconceptions and fears. Eating for two, however much you tell the lady to restrict because of a health condition like gestational diabetes, it may be with the mother-in-law or other family members. So it's important to counsel the entire family unit. Long-standing misconceptions like papaya can cause abortion, though there is no scientific basis for that. Some of these have grown over the girls and women in our population. So we need to very targetedly, specifically tell them quick fix solutions and tips of what is doable within their own households and the community. So the clinicians lack time and the patience, and also really lack the knowledge and skills for offering practical tips to the multi-cuisine complex requirements in the community. If a clinician is sitting any nook and corner in India, language is one of the first barriers, time is the second constraint, and thirdly, from which background she comes and what diet you're telling to do, she may not even relate to, how she can go back home and do that. And women's empowerment, of course, they don't have the liberty to do everything for themselves. It's many others in the family who decide. So the task shifting for nutritional assessment is the need of the hour. So we need to collaborate to build the capacities of the entire team of staff nurses and the assistants, whoever is looking after the pregnant women, and many of the point of care equipment where semi-skilled workers also can play their role very well. Availability of counselors, the advantage of the counselor is well perceived, but the availability of educators and counselors, really there is a dearth for that with 1.3 billion population. I do hope we harness the human resources in the way that they could stand to the advantage of the community. So ABC of Nutrition is a series of programs that we have started from Vigo, from the Pregnancy and NCD Committee, where the A stands for ahead of pregnancy, B is be cautious during pregnancy, and C is continuum of care, tag her for the rest of her life. This in the form of case presentations has been very well received, and now the whole community is waking up to the importance of their role in communicating with the target of the patients that come to them, not to lose that opportunity to do our best. So bringing in the behavior change by apps such as iMoms, which is also devised by one of our own members, Dr. Jaideep Malhotra from Agra, and it's still had a second place in the Atmanirbhar Bharat event. And the technology, if within 5 years, the girl who is 20 will embark on her pregnancy at 25, for example. These are the real tech-savvy youth and the future generation. We did a survey and documented and published the data on where do the girls go to get their information about contraception, or many who are using menstrual cups. When did they get the information? Because healthcare providers are not telling them, or they are not accessing us. 85% are through the digital and 10% to the peer group, only 5% to the healthcare providers. So beyond us, there is this ghost or the cloud, Dr. Google and the rest, who can also do the job even better than us if the uniformity and the robustness and authenticity of the messages are there. Then there's a huge initiative of Mamta TV, where the FOXI has vetted the contents of what should go on the TV in the waiting rooms of both the public and private sector. The Manyata initiative, where the breastfeeding and the relevant messages are given to the mothers of the Manyata certified centers by the staff nurses who encounter them at many, many touch points. And of course, the FIGO checklist, the 3 points available to us pre-pregnancy, during pregnancy, and post-pregnancy. A simple 4-point checklist, which is aligned to our Government of India list of what the clinicians can do in the shortest possible time. You just need to spend 5 minutes. You need to think nutrition and weight first, and you need to see to it that you consistently, persistently follow this up with conviction that this is indeed an important component for the health of girls and women. And slowly and steadily, you will see it translating into the impact that we desire. Maybe even one focus of anemia, make your practice anemia free. That is our campaign. Defeat diabetes is another such. So if we join hands with all the stakeholders that were present today, my very distinguished co-panelists and the speakers for today, I think we will leap several steps forward in creating the change that we so desire. Thank you very much for your kind invitation and your kind attention. Namaste.
Thank you, Dr. Diwakar. That was really a brief and whirlwind tour of everything that's happening around. That's great. Thank you so much. We are running over time by almost 15 minutes. So unfortunately, I'm told by the organizers that we cannot take any more questions from the audience. Really sorry about that. But I think all of you know where to find our panelists, so you could directly contact them and ask them follow-up questions. So I would like to say that we have learned a lot across these two panels, the first evidence reviews and then the implementation experiences, and they have actually resonated with each other in terms of the importance of the supply side, the need for a strong supply side being in place, the need for the intensity of the intervention, and also the recognition from the implementers that layering the existing platform with multiple interventions may not be the best way to go forward. However, I also realize that the evidence itself is based on fewer studies, particularly around health and nutrition. So I think this is a call for actually building more evidence, and in doing so, identifying innovative approaches to how to try to leverage the platforms currently with the knowledge of the time constraints and all the other barriers that women face, and all of us here recognizing that women's collectives are not a panacea or cannot be seen as a putting everything on the shoulders of these women's collectives as a development agenda. But I'm sure that there is a value of the collective and the group dynamics itself that helps in moving some important aspects of health and development. So what are those, what could be those interventions, and how do we build evidence around those? I think these are all thoughts for consideration, and it's a very short time frame for us to elaborate on this. I think we just have seen the tip of the iceberg, and we need to deliberate more on this. Thank you for inviting me to be part of this excellent panel, Bharti, and I'll hand it over back to you. Thanks.
Thank you so much, Rashmi. And all of you would agree with me that we have learned a lot today in this short span of 2 hours. Initially from the presentation by Dr. Sapna and Dr. Audrey, we saw the evidence, and then we had different views from panelists. I think this has been a very enriching experience. I would now request our chair to give her concluding remarks. Neeta ma'am, may I request you to give your remarks? Yeah.
Thank you. I think Dr. Rashmi has really beautifully summarized most of the discussions. Since we are running out of time also, I'd not like to take much time, but this has been really a learning experience for me also. The presentation by Sapna and Audrey, of course, we have heard a little bit of that, but again, going through it and the recommendations that they have made on what kind of interventions can really be impacted through SAGs and the others, what kind of, I mean, to get the impact, what kind of intensity or other things are required. That was a very good, very insightful kind of understanding is coming out of that. So thank you very much for all that. And all the other speakers have thrown light on different aspects of this topic that we were discussing. Of course, I've been working with a few of them, Saurav and Dr. Vani from UNICEF. Madhu also, she's a partner in this. So I'm really glad all of us are here together to take all this inputs from this nice panel. And Mr. Sampath Kumar, he's got a lot of experience in this area, has been working in UP, and I've been off and on connected with him also, and he's been doing excellent work in Meghalaya. And the confidence that some of the colleagues are showing in this, the SAGs as a means or as a platform to work with for this. I understand that light touch, as somebody said, is not really the way forward. It needs much more intensity, and definitely that is the way we need to go. Dr. Sampath also pointed out to how we need to bring together the supply side mechanisms with the strong demand structure that the SAGs bring. When he's looking after both the sides of the program, the health also and WCD and rural development, it really is the best kind of convergence that can happen there. So, thank you very much for all those things. And in conclusion, I would say that, for want of a better strategy, I mean, right now, this is the institutional structure that we really have. And going individually is definitely going to be much more difficult. And as a group, there is a lot more that, can be passed on. And we need to improve our strategies, of course, but I do believe that this is probably a very good strategy to go forward in this direction. And definitely there is a requirement for doing a lot more studies, because there is a need to make corrections in our strategy also, in our approaches also, like Sapna and Audrey pointed out. So, and as I said right in the beginning also, these kind of interventions require a lot of time really to show impact at a large scale. And our interventions also have started only in the last few years. So I'll be really looking forward to much more studies in this area and much more inputs to NRLM. So again, thank you very much to all the organizers for organizing this wonderful discussion and calling me to be a part of this. It's really been a great experience. With that, I'll end here. Thank you very much.
Thank you so much, ma'am, for your words of wisdom and sharing your experience. We have learned a lot, and we have learned from both from the NGO side as well as from the administrator side. People working at the grassroots level unanimously express that let's not burden the women who have come together for microfinance objectives, and we cannot make women take care of they themselves take care of their own health and nutrition for women who have come together for the livelihoods. It's too much to expect from them, and that's why probably the systematic review is showing that we can expect limited outcomes. And also the behavioral change interventions, when we are implementing, we can expect impact on behavioral outcomes. But for these interventions to have an impact on nutritional hard outcomes, for example, reduction of stunting or reduction of low birth weight or increase in maternal BMI, these are multifactorial, and it will take much longer time and much more intensive focused interventions. And I think our expectations also have to be reasonable so that we do not get disappointed. And I think there are some studies which have shown reduction in neonatal mortality, reduction in some of the outcomes, which are very, very important. And I think we should be happy with these kind of outcomes when we see reduction in neonatal mortality or increasing dietary diversity. That itself is a good outcome, and it will take a much longer time to see an impact on the anthropometric outcome, for example. So our expectations also have to be realistic and reasonable. And Mr. Sampat Kumar brought out quite an important issue, and segregating interventions into self-help block box and entitlement box. He gave very nice example that, for example, kangaroo mother care can be achieved through self-help box because there is not much supply side intervention required. Whereas if we think of reducing anemia through IFA supplementation, a lot depends on the supply side. So I think this kind of like segregation and having realistic expectations is quite important so that we are not sort of disappointed with the outcomes, and we have to have reasonable expectations. Thank you so much. I would like to thank the speakers, Dr. Sapna, Dr. Audrey, all the panelists, Dr. Hema, Dr. Saurabh Bhattacharya, Mr. Sampat Kumar ji for sharing his experiences, Ms. Madhu, and Dr. Sanjeev Kumar. Thank you so much for sharing your time at very short notice.